So again, thank you for coming to my little presentation on the high flow nasal cannula and assessing for respiratory distress. Again, my name is John, representing JFK University Medical Center, and of course I'm going to Ramapo College for my master's. I provided you with some handouts. So what we're going to go over today primarily is our high flow nasal cannula flow chart algorithm, which was provided by Dr. Kaur. It's basically a way for us to assess eligibility and criteria for admitting patients to start high flow nasal cannula here on the floor. Some resources for that. So we're going to be using this respiratory severity score to help us determine this eligibility and if we have the capacity to take care of this patient, and if they present with the symptoms that says they're allowed to be here or if they need to be transferred out. Right? And then also we utilize at the same time a PEWS. I don't know if you've used that before, a pediatric early warning score, just to see in general if they need more care, if they need more eyes on the patient. All right. Here are some case studies. I provided 3 case studies for this presentation. So with those, we'll go into detail about applying the RSS and the PEWS to these case studies so that it makes sense when we go through the flow chart, whether these kids can stay with us and start high flow.
Okay.
All right, so some objectives we're gonna cover with this presentation. For one, we're gonna review high flow nasal cannula, the flow chart that you have in front of you, including the eligibility and contraindications for being admitted with us. Number 2, we're gonna apply the respiratory severity score, the RSS, and the PEWS to case studies of respiratory distress, so we'll look at those case studies. And then number 3, we're going to review the use of high flow nasal cannula and any management of equipment and any troubleshooting that we need to do. That's more of the psychomotor skills that you're going to develop, and I know you're taking care of a high flow patient now, so that'll be good for you to kind of like hone in on practicing what you just learned.
Okay.
But we could play with the equipment as well. And then these top sections are more so for your cognitive development, so you could have the knowledge and then apply that to specific situations. All right? And then eventually, affective domain, we want you to develop that confidence to be able to manage these cases and know what to do when a patient comes in, they might need some high flow, and then just knowing if they can stay with us or not. So real quick, we have a little question to start us off. You're working on the PEDS unit today. You just finished rounding on your patients at 12 p.m. on a very busy shift. In what order do you see the following patients? You have A video EEG admission of an autistic child, may need a 1-to-1 sitter. You have B, a broncholytic 1-year-old breathing 50 breaths per minute. C, you have a post-op appendectomy. He or she still needs her 10:30 a.m. antibiotics, and it's already 12 at this point. D is documentation of your head to toe assessments. You have not done it, and it's already 12, and you haven't done your 8 o'clocks yet. And then E is a 3-year-old admitted for dehydration. They're now eating well, but the 6 a.m. labs are still not done, pending discharge, and mom's just upset about them still being here with all the delays. So how would you prioritize what patients you would see here?
B first.
Nice, okay. We have maybe some signs of respiratory distress going on.
Yes.
Well, now going on, what's the next patient we might want to see? No completely wrong or right answers. It's just also, generally a guided way of prioritizing your patients.
Okay. Maybe I would pick A because they need a possible sitter. They might be unsafe.
Nice, safety issues. Okay.
And then C because they definitely need that med.
Okay.
And E. And then D.
Amazing. Exactly right.
Oh, okay.
Isn't that good?
Yeah.
Look at that. You trust your gut, right? Trust your feelings about these things. So first is the broncholytic because that patient is showing signs of respiratory distress, right? Then the second one is a safety issue. They need a 1-to-1 sitter. An autistic child, here we get video EEG patients all the time, and sometimes they're a little bit more inappropriate with their behavior. So you might need a 1-to-1 sitter to help watch that. But it's second to something you could immediately more intervene on and respond to, which is the respiratory distress kid. Third is the post-op appendectomy. Still needs 10:30 antibiotics. Delays aren't the best, but in terms of comparison to the other patients, they could wait until they get their antibiotic. Fourth is that patient's stable,
Mhm.
right? So you don't need to do any kind of immediate care with them. It's just more social aspects, pending discharge, waiting for the labs, which will eventually be done. Then last is your documentation. So very good. Nice.
Thank you.
So what exactly is high flow nasal cannula? High flow is a type of oxygen therapy that gives a higher rate than normal oxygen, right, or low flow, of warm humidified oxygen, allowing for more comfort. Especially that warm humidified aspect of it all helps that the air coming in feel more comfortable especially for our pediatric patients. It's a step up from regular nasal cannula, which is our low flow systems. The high flow delivers more oxygen, helping to reduce work of breathing and improve oxygenation. Some nursing considerations, things to think about. We primarily start high flow on patients who have mild to moderate respiratory distress. Anything that's greater than that, you might start exploring CPAP, BiPAP, intubation, right? Nursing considerations, continuing on that, you want to monitor their pulse ox, their respiratory rate, and their work of breathing. You also want to watch for skin breakdown around the nares and the ears, just because of that moisture around the nares and the nose, and then just any kind of pressure on the ears might be tugging on there. So just periodically checking on those skin sections of their skin. And then FiO2 is adjustable between 21 to 100%, but you do need an M&D order to clarify, because in certain situations they want you to stick to a certain FiO2, but majority of the time they'll provide a range to you and you'll titrate as such. Just don't go beyond that scale that they gave you.
Okay.
Right? So what you have in front of you is a high flow nasal cannula flowchart, again provided by Dr. Kaur. It is evidence-based, and it is primarily dependent on the RSS table, which is on the bottom of that. So we'll go over that in detail about how to score a patient and give them an RSS score. But for the most part, this flowchart on the left shows the eligibility criteria, on the right shows the contraindications, and in the center is just kind of the timeline to which we're treating this patient and what we're doing, what we're charting, what we're monitoring. And then to the right lower aspect is when we start to play with the thought that they might be transferred out, that they're not stable on the high flow. The center part again is just following the trajectory that they're stable on the high flow and eventually might just need some weaning after some time on high flow. And then to the left here is just like ED indications for them and what they need to do in order to be transferred over to us.
Okay.
All right? But I'm gonna go over each section in detail because it's such a small chart and I don't want you to squint.
Okay.
So let's break down the flow chart step by step. Real quick, let me just check my camera's going. Okay, good. So the eligibility to start high flow nasal cannula here at JFK is the following. They need to be between 3 months and 21 years old. So anyone younger than that, based on the literature, younger than that might be more predisposed to severe respiratory distress and their plan of care escalating to needing more needs that might not fit our criteria here. So that's why we have a specific age range for that. Their primary diagnosis should be the bread and butter of what we get here, which is bronchiolitics, pneumonia, asthma exacerbation, croup, mild or moderate respiratory distress from other respiratory illnesses or viruses. Again, bread and butter of what you see when it comes to pediatrics. Nothing like adult, like COPD, nothing like that, because kids don't tend to have that. And then any kind of viral illnesses, they have a secondary bronchiolitis that usually goes on, so we could usually treat those.
Okay.
All right. If it's like more of like a severe pneumonia, that might not be in our realm. It's more of like, again, the other criteria is that they have to be clinically stable.
Okay.
And then when we start playing with the RSS, you're going to see that our score needs to be between this 1 and 8 range. Anything over 8, we start again exploring the idea of transferring out to another facility for their PICU services. Some contraindications at JFK. So when we find these contraindications, we do have to consider transferring them to a facility with PICU capabilities, or if they're 18 to 21 years old, they can go to our adult ICU. All right. So here are the contraindications. Signs of severe respiratory distress, impending respiratory failure, any RSS scores greater than 9, altered mental status, need for positive pressure ventilation or a high FiO2, which means greater than 50%. If they have a neuromuscular disorder or conditions that impair respiratory effort, so maybe some of the chronic kids you've seen, we can admit here and start them on high flow because they usually need more pressure. things that we shouldn't manage here. And then known suspected airway obstruction, or a history of prematurity, chronic lung disease, or other chronic respiratory disease. And we clarified with Dr. Kaur, so let's say there is a 10-year-old who has medical history back in the day of being born at like 32 weeks. Because maybe that kid hasn't been hospitalized for quite some time, maybe they can still fit our eligibility. But if it's like a 2-year-old who was born premature, but they've been going to the hospital like 3 times a year, maybe not our case. Does that make sense?
Yes.
That it's like that kid has more risk of getting worse and not being a stable high flow with us.
Okay.
Right? Does that make sense with like what counts for not being allowed here, and when do we have to start considering transferring out?
Yeah, it does.
Yeah. Okay, good. These kind of like really contradict each other in terms of like, this is eligibility, this kind of screams stable, right? Things that we usually do, ages we usually get, they have to be a stable respiratory status and very mild to moderate respiratory distress, versus this is like all stuff that kind of gives us that nursing gut feeling that maybe they should be in a PICU and need more support. So that center part of the algorithm is basically what's laid out here. So the step-by-step guide for starting a kid on high flow. Let's say a kid presents with respiratory distress, mild to moderate. The first steps you're gonna do is suction, right? You wanna clear that airway, get all that gunk out of there. Maybe we'll start them on low flow oxygen, and then you're gonna make sure they're hydrated with either PO, NG, or IV, all right? You're gonna initiate high flow here at 1 to 1.5 liters per kilo per minute. So essentially you have to know what the kid weighs, and then you're gonna multiply 1 to 1.5 by that number to start us on the liter flow we're gonna start with. And then max here is 2 per kilo or up to 40. We're gonna practice with our case studies, all right? You could also titrate the FiO2 up to 50% to maintain pulse ox greater than 90. So what that means, if our patient, when they're stable, needs greater needs than 50%, let's say they're steady at 60 or 70%, that means their needs are higher and they need to be transferred out because we can't adequately, keep them here, especially with such high needs. You're also going to place the patient on a continuous monitor and pulse ox. Make sure you put an MD order because that requires that. And then in terms of timeline of reassessing, you're going to reassess the heart rate, respiratory rate, pulse ox, and RSS at a certain time frame. So for the first hour, you're going to do it 1 at the start of the high flow. You're going to do it at the 30-minute range, then you're going to do it at the 1 hour range. So 2 Q30s. Does that make sense?
Yeah.
And then per the algorithm, if they're stable after that first hour, after starting high flow, then you're going to do Q2 vitals and Q2 RSS. So basically 2 Q2s for a 4-hour period. So the first hour, 30-minute, 30-minute. Then the following 4 hours is a Q2, Q2. Then if they're still stable, like what we have now, you're gonna go to Q4 from then on, all right? And then the next step, huddle with the RN, RT, and MD 60 minutes after initiation of high flow. So this is a crucial part because at this point, you all are on the same page whether this kid is stable on high flow or do we have to consider transferring out. So if not stable at the 1 hour mark, you're gonna huddle again at the 1.5 hour mark to see if your reassessments at the 1 hour are effective. So by the 1.5 hour mark, you should be able to tell if this kid is actually stable based on the increases in the flow, or again, if we need to transfer out. Okay? So that's important where you do a 1 hour huddle and potentially a 1.5 hour huddle. What I wanted to show is an example. Basically, if this was a real shift, how would we have a timeline of a stable high flow patient? In terms of your charting, in terms of the checklist that I showed earlier. So let's say at 8 a.m. you started the high flow, all right? Based on the algorithm, you did all your suctioning, you tried already low flow, you already have a kid on IV fluid, so all of those are checked off, but now they're still looking like they need high flow. You're gonna initiate the high flow, start some vital signs, put them on the monitor, and do an RSS score, right? That RSS should be between 1 and 8, right? At 8:30, based on the algorithm, you're gonna do that Q30. you're gonna do another set of vital signs and RSS. At the 1 hour mark, you're gonna do vital signs, RSS, and the huddle. So that's the additional thing at the second 30 minute, which is essentially the 1 hour mark, all right? So then at 11 o'clock, since you were stable and good at the 1 hour mark, now 2 hours later, Q2, right? 2 Q2s you're gonna do. At 11 o'clock and 1 o'clock, do a set of vital signs, do an RSS, hopefully it's still below 8. Then you're gonna, after that, go to Q4. So then 5 p.m. and 9 p.m., if still stable, Q4, vital signs and RSS. That makes sense, that timeline? Now what if it's an unstable high flow? So now with that flow chart, let's say we're going to the side is what we're trying to look at. So at 8 a.m., do the same stuff for the first hour, initiate high flow, start the monitor, do an RSS. 30 minutes later, vital signs and RSS. 1 hour mark, vital signs, RSS, and the 1 hour huddle. At that point, you're discussing with the physician and the RT and whoever else is involved, is this kid doing well on the high flow? Because this is the unstable timeline, let's say the kid wasn't doing well. At 9:30 a.m., as per the algorithm, you're gonna max out the settings, which is either 2 per kilo or 40 liters. Or whatever changes the physician suggests. Maybe they want another suction, maybe they want a treatment, etc. So essentially that 1 hour mark is let's do what we can to see if we can still fix this situation. 9:30, we're still unstable. You're gonna do another set of vital signs because they're still on the monitor. You're gonna do another RSS. You're gonna huddle again, and you're gonna start initiating the conversation about transferring to PICU. Because at the 1 hour mark, remember you pretty much maxed everything, did all your treatments. By the 1.5 hour mark, it's either another set of, maybe the physician has an idea of what else they want to do to treat, but you really should just spearhead that conversation about transferring. Like maybe this, kid just needs to be going to a PICU at this point.
Okay.
I like to think by the 2 hour mark after you initiated high flow, you already could be pretty confident about what this kid needs. And that's where it's important to be efficient and communicate what the RSS is, what your findings were, what you're assessing at bedside, and then communicating to the physician if we need to stay or not. Does that make sense?
Yeah.
Okay. So transfer criteria at the 1.5 to 2 hour huddle, if unstable on high flow. So the reasons why we would transfer them out is inadequate response to the high flow. They have severe respiratory distress. Now their RSS is 9 or greater. They have impending respiratory failure. Their apneic or FiO2 needs are greater than 50%. And then some considerations when you do transfer. One, of course, you're going to call the transfer center, which is either Hackensack or Robert Wood, whatever you need at that time. You're going to tell the physician to make that call. They're going to place an order in, and then based on that nursing checklist that I'll give you, you write the times to which they make this phone call, the time they put the order in. At the same time, your kid is probably not looking so great, so you want to consider activating the code if necessary, and then consider bridging interventions like CPAP, BiPAP, non-invasive ventilation, and intubation. And you said you're comfortable with like CPAP, BiPAP, okay, so at least you know the know-how of like putting the mask on and stuff like that. Hopefully it doesn't need to go into intubation, but if we do have on-call intensivists till like mid-June, and then you could always still call the pediatric code or the PDD if you need assistance. And there's also a neonatologist who's on 24 hours? Yeah, neonatologist is on 24 hours, 24/7, and our hospitalists are on 24/7. All right, so the hospitalist may not directly have intubation skill set, but the neonatologist should, and you still again have like the code team.
Okay.
Just like basically call everybody if you think you're needing intubation. All right, you could again PDD, tell the hospitalist, call the labor and delivery, the anesthesiologist. There should be that as well.
Okay.
You have a few resources for that. More details on the transfer process. So if they are emergent, their arrival should be 30 minutes or less. Urgent is what we're typically going to choose, which is 60 to 90 minutes. And then routine is whenever someone is available. But just note that the times for urgent or routine can be bumped to even longer if an emergent transfer were to be required. So you really only want to put emergent when it's like a kid on multiple pressors, multiple drips, maybe like close to intubation needs, that's emergent. If it's a high flow, that's like they're okay, but they just need to be somewhere else, that's like the urgent.
Okay.
Okay, so now let's look at the tools we use to assess respiratory distress. You have the RSS and then you have the PEWS. Really quickly going through the RSS, it's based on 4 parameters: the respiratory rate, the pulse ox, the retractions, and the breath sounds. You can see each 4 category over here, and then based on the severity and worsening symptoms, you're gonna add more points. So essentially with the respiratory rate, if there's an increase in respiratory rate based on the age, that's when you start to score higher. On the pulse ox, this one's a little bit more difficult to score because basically if they're on oxygen already, you're gonna automatically give them 3 points.
Okay.
But if they're on room air, because that's what it's asking for in room air, let's say they're sitting 90% on room air, then you could easily score like 2 points,
Mhm.
all right? Sitting well and pretty at 96%, 0 points as an example. But this obviously shows that they already have some kind of need if their oxygen is less than 90, okay? Auscultation, from left to right, you have clear, no crackles or wheezing. 1 point is mild expiratory crackles or wheezing or scattered crackles. 2 points, now you're more definitive that there's like an expiratory wheeze going on or coarse crackles. And then 3 points, it's both inspiratory and expiratory wheezing or coarse crackles, diminished breath sounds, or minimal air movement.
Mhm.
Okay? Retractions, from left to right, you have no retractions. Then 1 point is just one section of the torso, which is subcostal or intercostal. 2 points is 2 sections of the torso, subcostal, intercostal, or nasal flaring.
Okay.
Or nasal flaring is an automatic like 2 points too. Then 3 of the following is subcostal. It's basically 3 sections of your torso, but plus you're also doing nasal flaring and like head bobbing.
Okay.
All right. Based on what your total score is, that's when you know what severity it is. So 0 to 3 is normal, 4 to 6 is mild, 7 to 9 is moderate, and 10 to 12 is severe. So our range right now is this normal to moderate. We shouldn't be accepting anyone with severe respiratory distress.
Mhm.
Okay. So now another question, based on the RSS, what physical presentation of severity of respiratory distress automatically adds 3 points?
Feet.
We'll go over. So head bobbing, right? You could also use
Oh.
that tool, yeah. Just again, practice, right?
Mhm.
So you're looking at the 3-point section.
Mhm.
You're seeing if head bobbing exists in the 3-point section.
Mhm.
You're seeing if diminished breath sounds is there, pulse ox less than 90 on room air, inspiratory and expiratory wheezing, or all of the above.
All of the above.
All of the above. And the point of that question is because I want you to start getting conditioned to seeing any of these and knowing those are automatic 3 points,
Okay.
right? Sometimes we listen and we think, oh, or we see inspiratory and expiratory wheezing and we're like, oh, that's okay.
Mhm.
But based on the severity score, that actually adds 3 points. And maybe it's a quick fix with just albuterol, but it's still something to note on the score.
Okay.
We also use the PEWS, so the PEWS is right there for you. Again, it's just an early warning score for us to see if one patient needs more monitoring, more frequent monitoring. Going from left to right, behaviors like appropriate to lethargic. Cardiovascular, their cap refill is a little bit quicker and then it slows down, and also potentially some tachycardia going on. So if their heart rate is 20 above normal, then you're going to score them a 2. If it's 30 above normal, you're going to do a 3, or bradycardia. Respiratory, 0 is within normal, no retractions. Score of 1 is it's 10 over their normal, mild retractions, or any continuation or start of oxygen is automatically 1 point, right? Maybe the kids you were more familiar with, a baseline trach would have like a 1 point. 2 points is 20 above the normal, moderate tractions, and that's just more of the FiO2 needs. And then score of 3 is 5 below normal, severe retractions and grunting. Green means you're going to stay the course and do Q4 vitals. A score of 3 to 4 is Q2 vitals, and you should notify the physician. And a score of 5 or greater, which is red, means notifying the MD and doing probably Q1 vitals at that point, probably need to be transferred out. Okay. All right. So based on the PEWS, what vital sign automatically adds 5 points? So we didn't go over this just yet, but I want you to see the PEWS. And on the bottom side of the chart, is there a certain kind of vital sign that automatically adds 5 points?
Hypotension or non-rebreather?
Nice. Yes, hypotension. So make note of that if a patient has a lower blood pressure, that's a red flag for you. And it automatically adds 5 points, which is like it's already like a Q1 because you want to be wary of sepsis. All right, now we're going to review some case studies. Let's apply the RSS and the Pews. So case study number 1, we have a 5-year-old who is transferring from the satellite ED to our pediatric floor. As per the sending facility, the patient was awake, alert, oriented ×3, no respiratory distress. They just require 2 liters because their sats were in the 80s. But the patient arrives to the unit presenting as such. You call the patient's name to introduce yourself, but he appears very tired. Pulses are 2+ with a cap refill of 3 seconds. You pull the patient's shirt collar down and see no suprasternal retractions. On auscultation, the patient has crackles bilaterally but sounds quieter in the bases. What is the RSS and the Pews? Here are your vitals.
Okay.
Most noteworthy is the weight, right? We're gonna need to know the weight for the high flow.
Yeah.
BP 90/52. We know now on 2 liters, he's on 95%. But before then, he was like 80s, right?
Okay.
And also, we don't know the respiratory rate, so we're gonna figure it out. I'm gonna play the video, and you have to just count.
Okay.
You're good with counting your respirations?
I hope so.
So I know it's usually on the monitor, but I guess we gotta really, this one's a little bit hazy. I'm gonna give you some clues. This is 14, 15 seconds.
In
So whatever you count, what are you gonna multiply by?
4.
Nicely done, okay. I'm gonna play it one more time.
Okay. 8.
Not bad. So 5 or 6, right? Times 4, which is 20 to 24.
Okay.
You got 7.
Yeah.
I saw where you got 7. So not bad. Not bad. Close enough.
Okay.
Basically, he's not breathing too fast, right? I'm gonna go to the next one. So now we're gonna score together. So you have the RSS next to you, right? Okay. So what was he breathing? Let's say he was just breathing 20 to 24.
Okay.
All right. What for the 5-year-old? You have the case studies right there, right?
Oh, yeah.
Yeah. So use that. Or yes, a 5-year-old. We're gonna look to the left and then see where his respirators were.
So he doesn't get a point.
Nicely done.
Yeah.
Okay. Now SpO2 in room air, based on the case study. You could also
He
use
was
that
80
as a
though,
reference. He
that
was
was-
80, yes.
So
So what point would you give him?
we give him 3.
Nicely done, 3. Nice. And then auscultation, what did we hear?
Crackles and diminished at the bottom.
Is that what that says? I don't know.
I think it's patient has crackles bilaterally, but sounds are quieter in the bases.
Bases. So what score would you give it?
A 3.
Nicely done. And then retractions?
There are none.
No retraction. Oh, my fault. I did not tell you because I wanted to show. What did you see in the video?
Retraction.
So there's no suprasternal, right? Because we said it, but we want you to note what could be happening there. Anytime you see the belly, that's subcostal, right?
Okay.
Right, that's the belly because it's below the intercostal spaces. And then you see some intercostal use right up there too, right?
Yeah.
So let's say intercostal and subcostal. So what score would you give that? If it's 2 sections of the torso.
2 points.
2 points. There you go. And now what's your total?
It is 8.
8. Nice. 8.
Alright.
So we built this into Epic, so you can chart all of these, so you don't have to do the math yourself. All right, you just need to know the presentation.
Okay.
And then actually the vitals you chart, they carry over into the RSS too, which is nice. Now the Pews.
Okay.
How did we look? What was the description?
very tired.
Okay, tired.
Tired.
What's his refill?
It was 3 seconds, I believe. So
3?
it was, yeah.
Okay. And he was a little tacky, I think. Could have been. Use your nursing judgment for, because you know how it says 3 seconds, it could be this one or it could be that one, you know what I'm saying?
Mm-hmm.
So just use your nursing, and then respiratory rate?
It was 24.
24,
So it was
mhm.
2.
And then, yes, and then how about his retractions?
It was,
I think they were
yeah.
okay, yeah. So what is his P's? 2, 2, and 1. 5, right. So what interventions will we do?
We'd call the provider.
Consider PICU transfer, maybe.
Yeah.
5.
Okay.
So based on our score of 8, do we start high flow?
Yes.
Yes. RSS 1 to 8. There you go. At what liters do we start high flow? You could use all the cheat sheets you want.
It's his weight multiplied by 1 depth to 1.5.
Nicely done. So if we were 20 kilos,
20 liters.
nice. There you
Okay.
go. Do we transfer out? Now, what are our parameters for transferring out? If our RSS is 8, and you could use that, what's the contraindications on our end?
Conditions for altered mental status, stroke failure,
Or what RSS do we need to consider transferring out?
a 9.
Right. So no, not yet.
Not yet.
Right? But we discussed the P's with the physician.
Mm-hmm.
It was a red score, so we could talk about that. But in terms of the RSS, we don't need to transfer out just yet. We want to try to see what we can do. All right, next case study. You ready?
Mhm.
Okay. You got a hang of it?
I
a
hope
little
so.
bit. You've been scoring very well so far, so it's a good thing. A 3-year-old presents to the ED with shortness of breath. You know she is breathing about 45 times per minute, has moderate intercostal retractions and coarse crackles. She's playing with her mom, drinking sips of juice, and has a cap refill of 2 to 3 seconds. Vital signs are as follows: rate of 45, 94% on room air, heart rate 134, BP 101/64, 98.5. She is 15 kilos.
Okay.
Ready to score?
Sure.
All right. So RSS, what's
So-
our 45?
45, and she was 3 years old.
3 years old.
So that puts her 3 points.
Nicely done. What's her pulse ox?
94 on here, so that's 1.
Nice.
Mm-hmm.
Auscultation?
2.
2. Nice. And then retractions?
2.
2. Sorry, 1.
And 1. Sorry.
Just had the, you know, it's a little trick question because it said moderate intercostal, right?
Mhm.
So it's just one section of the torso, but moderate you might be leaning towards like a 2. So I wouldn't blame you for that one either.
Okay.
If it looked like it was a little bit harder breathing than you typically want, so I don't blame you. What's your total for RSS?
7.
7. Nice. Now our pews.
Okay.
What's our girlie doing,
She's-
behavior wise?
She's playing, so she's a 0.
Cap refill?
It would be a 1.
Nice.
Respiratory, would be a
Moderate intercostal, right?
2.
Nice. So what's our pews?
A 3.
Nice. Very good. So do we start high flow? Remember the score? 7.
Yes.
Yes. At what liters, trick question, can we max high flow at JFK? It's also on the algorithm.
It's her weight times 2.
Nice. So what's her score? What's her weight? 15, right?
Yes.
So what-
30.
Nice. Do we transfer out?
No.
No, not yet. Nicely done. Last case study. You ready?
Yes.
Can you guess what it is?
No.
All right. A 1-year-old on the peds unit presents with the following presentation. He has head bobbing,
Mm.
is drowsy and lethargic, and has diminished breath sounds. Cap refill 3 to 4 seconds, BP 71/49, temp 98.9, 89% on room air. He pushed his bottle away for the past 5 hours, and he weighs 12 kilos. Same thing, we're gonna count. Make it a little bigger for you, poor guy. All right, 12 seconds, but we'll do the math together, just count.
Okay, 44, 45,
What did you count in that?
11.
Okay, and
I did times 4.
see, there you go. But you got it, you got the idea. So let's say it was a breath per second, right? If you counted 11
Mm-hmm.
in 11 seconds. So your answer is,
Like,
you can say multiply by 5. How about that?
so like 50.
50s, yeah. So 11 times 5, 55 to
Yeah.
60, okay? Alright, yeah, so we are breathing. Alright, so he was breathing, he is a 1-year-old, breathing 50s.
3
So-
points.
Nice. What is his pulse ox in room air?
It was 89.
89. Mm-hmm.
And
What do you hear?
Diminished breath sounds.
There you go. And then retractions?
Yes.
Where? Oh, actually in the video, right?
Yeah, video.
Let's see.
Intercostal.
Mm-hmm.
And sub.
Subcostal. What else is going on in the description?
He's head bobbing.
Head bobbing. There you go. So that score is a, with head bobbing, 3. Nice. Just sign up. Ay, 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 baby, baby. All right, so we got it. So what were we doing? All right, 3 points. 3,
3,
which
12.
is 12. What's our pews?
Our pews was lethargic, so 3. His cap refill was 3 over seconds, 2. 3. 'Cause it was.
Okay.
Oh, I just. I'm sorry. It was
You know,
20 above the parameter.
20 above prem, that's okay. And then the moderate retractions, right?
Mhm.
But sometimes if you, as a nurse, say this is severe, because it could be a subjective experience,
Mhm.
that's something you want to chart. I think that severe retractions, and we won't blame you if that's what you report to the physician.
Okay.
Right? At that point, they should see the retractions themselves if you're saying severe. Okay? Also, hypotension, right?
Mhm.
71 over 49. So our Pews is very high at 12. Do we start high flow?
Yes, but we're not transferring.
At what liters do we start?
The highest? No.
You could. That's a good nursing judgment that you just go straight to the 2, right? Because this kid looks, ready to
Yeah.
crap out. But what do we technically start with?
His weight times 1.
And if his weight was 12,
It'd be 12 liters.
and then we could also start at 1.5. So what's another?
12 times 1.5. I'm not sure.
18. That's okay. Yeah. Just think half of this, right? Because you're just
Okay.
doing 0.5. So 6 plus 12 is the 18.
Oh, that makes it easier.
Yeah, for sure. Then what liters do we max high flow if it's 2 per kilo?
Oh, and it was 12.24.
Nicely done. Let's say the physician's like, we need to start 30 liters,
No.
right? They can,
Mm-hmm.
but they can't just stay here,
Okay.
right? Do we transfer out?
Yes.
Yes. That's a very high RSS. At this point, if our interventions aren't fixing it, we should transfer to a PICU. Right?
Mm-hmm.
Any questions about those case studies, the RSS, the Pews? We'll get more practice with these.
Okay. Yeah, no, I'm good.
All right, now the high flow equipment. You're familiar with high flow equipment?
No, we didn't have that.
You didn't have that? No problem. So we'll go over in detail. So there's 3 numbers on the high flow system. One, you're looking at the white number, which is the liters. You're gonna go at JFK, you can go from 1 to 2, right? Starting 1 to 1.5, maxing at 2. And then at math also, you have to be considered at this max of 40 liters per minute here at JFK.
Okay.
All right, so even if, like, let's say a kid is 25 kilos, right, multiplied by 2, you get 50, that means they can't be here.
Okay.
Right? But a 20 kilo multiplied by 2, you get the 40, that's the max at which we can host that kid. Okay. FiO2 is between 21 and 50% here, but that doesn't necessarily mean you can't go above 50, it just means what?
We need to transfer them
Out,
soon.
yeah. And then temperatures adjusted by the RT, the recommended range is 36 to 37. And like I've been saying, just because it is our max, it doesn't mean you can't go past this max per the patient's needs. So if your kid's satting 89% and they're already on 50, right, you could bump up to 60, but you have to just tell the physician, like, hey, we're at 60 now because we were satting 89, now he's going up to 91, but based on our protocol, we can only hold it until up to 50%, so do we start considering transferring?
Okay.
Some troubleshooting tips. If there is no flow, check the connections, making sure there are no kinks and the tubing is secured to the wall, to the humidifier, and to the nasal cannula itself. If there's water in the tubing, I just tend to reposition the tubing away from the patient so the water can the condensation can drift away to reduce areas of water collection. And then drain tubing again if needed and just like kind of use gravity as your friend. If there's discomfort in the nares, you want to assess for skin breakdown. You want to use skin protectors on the cheeks. And then check the cannula prongs. They should be less than 50% of the diameter of your nares.
Okay.
All right. And then just as a general tip, always check the flow settings against the order. Confirm the flow and FiO2 and that the power is on. That's sometimes usually it. Maybe you have to reset the high flow again. It doesn't hurt if you turn it off and on again.
Okay.
All right, for like a 10-second window, that won't damage or hurt the patient. All right. Some room considerations. Only rooms 4, 5, and 6 can accommodate for high flow. So 6, 5, and 4.
Okay.
Charge RNs, we ask that please leave these rooms to be filled last, if possible, to accommodate for potential high flow admissions.
Okay.
And that's about it. Thanks for learning.
All right, thank you.
And then we're gonna just play with the high flow.
Okay.
All right. Any questions about the algorithm? It all kind of lays it out there. Hopefully straightforward enough, but that's why we want to break it down step by step, so each step is not new to you and you understand what's the eligibility, what's the contraindications, what do I have to do hour by hour, how do I score a patient using the RSS and the Pews, and then last step is actually working with the equipment and troubleshooting that and just knowing what our limits are here. But as a general tip, like when a patient comes in with high flow needs, there usually should be on the stable end anyway, so it shouldn't be like, I hope it doesn't instill any kind of fear, it's just a higher level of oxygen that they need. It's more so your assessment skills that you want to brush up on to see that if they escalate in terms of their needs, then you have a means of communicating to the folks, and this is a tool so that you could say, you don't have to stay quiet about that. You could say at this huddle, at the 1 hour, at the 1.5 hour mark, I have this tool to communicate and advocate for my patient.
Okay.
Instead of just feeling like you can. Sometimes nurses, they sit with a feeling, a gut feeling that their kid is getting worse, but they have no means of communicating that or who to tell. This kind of builds it into the system. So
Yeah,
you have
I like
a voice.
it.
Yeah, for sure.